at a board review. All right, you guys fine with that? Okay. All right, so when you're looking at an arterial blood gas, just like anything, there's a system of doing things. Okay, you have to figure out what system works for you. I'm going to present you one type of system to consider. Okay, so typically what you do when you look at a blood gas, the first thing you want to do is you want to determine whether the patient has an acidosis or not. Okay, do they have an acidosis or an alkalosis? The second thing you want to do is you want to figure out what's the primary cause of that acidosis or alkalosis. Is it respiratory or is it metabolic? The third part is that you want to define whether there's some form of compensation because of that acidosis or alkalosis. And finally, you want to interpret your oxygenation. Okay? I'm putting up this chart here because a lot of times prep questions will do this. I don't see it that much on board, but you should know it at least clinically. What are the normal blood gas ranges for kids? Okay. Sometimes they'll throw in a neonate or a newborn neonate and determine whether they are having normal oxygenation, things of that nature. So that's why I think you should know these values. Okay. As far as abnormal values, again, first you want to determine if they have an acidosis or not. So anything less than a 735 is considered acidosis. Whether it's metabolic or respiratory, it doesn't matter. Less than 735 is acidosis. If it's above 745, it's considered an alkalosis. Again, doesn't matter whether it's metabolic or respiratory, it's still an alkalosis. If you have a patient with an elevated CO2 defined as above 45, okay, it's consistent with a respiratory acidosis. If it's less than 35, it's considered a respiratory alkalosis. From a metabolic standpoint, if their bicarb is less than 22, it's a metabolic acidosis, and above 26, a metabolic alkalosis. So, putting it all together, if I have a patient with a PCO2 that's elevated above 45 and a pH less than 735, I have a respiratory acidosis. If the CO2 is less than 35 and the pH is greater than 745, I have a respiratory alkalosis. So, looking at this and putting it together, whenever you see the CO2 and pH move in opposite direction, it's most likely a primary respiratory problem, whether it's acidosis or alkalosis. Okay? For metabolic, if my bicarb is low and my pH is low, it's a metabolic acidosis. If my bicarb is high and my pH is high, then it's a metabolic alkalosis. Again, putting it all together, if I have my bicarb and my pH moving in the same direction, it's most likely a primary metabolic issue. Okay? All right. Again, you want to also identify if there's a form of compensation. We've all seen that in various things. I'm not going to go through this right now. We're going to go through that when we discuss questions. Okay? But suffice to say that typically the opposite system works as compensation. Meaning when I have a respiratory acidosis, we start to have a kidney starting to produce a metabolic alkalosis, meaning the kidney is triggered in pulling in bicarb. If it's a respiratory alkalosis, the kidneys are going to lose bicarb and you're going to have a metabolic acidosis. As far as the primary problems being metabolic, if there's an acidosis, we're going to compensate by respiratory alkalosis, typically Kussmaul breathing or tachypnea. And if there's metabolic alkalosis, the kidneys are going to start, the lungs are going to start to hold on to CO2 and therefore create a respiratory acidosis in response. I'd say the two biggest ones to learn for boards is respiratory acidosis, okay, and metabolic acidosis. These are going to be the two most common things you're going to see as far as questions and also clinically. Okay, classic respiratory acidosis is a kid in respiratory failure or a kid with metabolic acidosis for whatever reason, typically like DKA or something along that line. Okay. I put these calculations here. I'm not going to go through these. You can review these on your own. But suffice to say, again, you can determine whether the compensation is appropriate or not. Oftentimes, the system that's compensating will not compensate 100% unless it's been a very chronic situation. But in those situations, labs are still going to be normal, abnormal. It's just going to be the pH that's normal. You can review this on your own, but just suffice to say, you can calculate to see if the compensation is effective or not. Again, the fourth thing that you want to think about when you're interpreting a blood gas, the effectiveness of oxygenation. So remember that all arterial blood gas, you can do this. You can't do this with a venous blood gas. Okay. Remember, there's various definitions that give you an idea about oxygen effectiveness. For example, hypoxemia is when you have the classic decreased oxygen content within the blood. Usually the PaO2 is less than 60 and the saturation is less than 90. I'm not talking about the congenital cyanotic heart disease kids. We're talking about normal kids right now. Okay. If you have hypoxia, remember this is inadequate oxygen available or used by tissues for metabolic needs. So it's almost like a shock type of situation. Right? I want to put a table up here so we can go through the various causes of hypoxemia, things you should know, because it's going to point you towards the right direction what the diagnosis is. So, for example, if you have ventilation-perfusion mismatch, which can cause hypoxemia, the classic things that you're going to see as far as illnesses include asthma, BPD, pneumonia, atelectasis, so some kind of lung parenchymal type issue. Usually their PaO2 is low. They can have a various range of PaCO2, okay? And typically they will improve with supplemental oxygen. Another cause of hypoxemia is hypoventilation. If you think about the way we breathe, it's controlled from the brain, and it'd be a problem all the way from the brain, all the way down to the neuromuscular junction, okay? Could be apnea, narcotic overdose, neuromuscular disease like Guillain-Barré, myasthenia gravis, some form of like Wernicke-Hoffman or SMA type syndrome. In those situations, what you'll see is that your PaO2 will be low, but your CO2 will be high because they're not ventilated. They can't get rid of the CO2, and they will typically respond to oxygen. Another cause for hypoxemia, some kind of extra pulmonary shunt. This is where the cyanotic heart disease kids come in. Okay, doesn't matter, what's going on. They will always have a low PaO2. Their CO2 may be normal or elevated depending upon how sick they are, and oxygen will not help. This is where we talk about the hyperoxia type test. We'll talk about that later in the critical care section, but suffice to say, they will not respond to oxygen. Their PaO2 will not increase. Another type of etiology of hypoxemia is intrapulmonary shunt. This is where you have diversion, okay, where you're going by areas that are not oxygenated. So examples, you have some kind of pulmonary AVM, there's pulmonary edema, and typically, again, the PaO2 is low, and depending on how sick they are, they can have a normal or elevated CO2. These kids as well will not typically respond to oxygen supplementation. Another cause, low FiO2, we usually don't see this. Typically, it's a high altitude thing. Unless you're practicing in the mountains or you're on air transport, it's really not of great significance, but just be aware of it. And their PaO2 and their CO2 will be low and will respond to oxygen once you give it to them. And finally, they can have a diffusion defect. There's a problem with the CO2 or the oxygen diffusing across the alveolar membrane. Okay? Examples: scleroderma, hepatorenal syndrome, pulmonary fibrosis, things like that. Typically, the PaO2 will be low, CO2 should be normal, and they will respond to oxygen. So another nice little table to keep in your mind when you're going through boards in your clinical patients. Other determinants of oxygenation is calculating the AA gradient. This is typically a pretty good one to know for the fact that when you look at this table, if you have a patient with hypoventilation, they typically will have a normal AA gradient, okay? But everything else will be low, like the PaO2. So this will be one thing that's going to be able to help you differentiate from the other ones, meaning this will have a normal AA gradient, but all the other ones will have abnormal AA gradients. So you can figure that one out right away. You could rule that one out. If the AA gradient's abnormal, it's like, oh, it's not hypoventilation. But if it's normal, you just ruled out everything else. Okay? So now you have to figure out why are they hypoventilating. Okay. So in summary, again, determine whether they have acidosis or alkalosis on the blood gas. Determine what's the primary cause. Is it respiratory and metabolic? Okay. Third, you want to make sure to see if there's any kind of compensation going on. All right. And finally, remember to look at the effectiveness of oxygenation. Okay. So what I'd like to go through now is just a couple questions to kind of, bring out some of these teaching points a little bit more. So a 15-year-old presents after ingesting some of his father's barbiturates. He suffered significant depression of his mental status and respirations. You see him actually 3 hours after ingestion where he has a respiratory rate of 4. After his ABCs are evaluated and corrected, a blood cast is obtained and reveals the following. His pH is 7.16, his PCO2 is 70, and his bicarb is 22. So, what is the patient's acid-base abnormality? Is it an uncompensated metabolic acidosis? Compensated? What is it? See, very good. So it's an uncompensated respiratory acidosis. So in this situation, this patient is not really compensated yet. The teaching point here is that kids with respiratory acidosis do not compensate very fast. It usually takes anywhere from 12 to 24 hours for the kidneys to start kicking in, holding on to bicarb, and offsetting or compensating for that respiratory acidosis. Again, as the barbiturate toxicity took hold, his respiratory rate significantly dropped. So, just to make sure that you guys are paying attention, what would be his AA grading? Normal or low or high? It should be normal. Okay? So we could do a blood gas here, look at the PaO2, calculate the AA gradient, it should be normal. Okay? Very good. All right, next kid, a 15-year-old comes into ER brought in by EMS because she was having abdominal pain and vomiting. She has a negative review of systems except that she lost 5 kilograms in the last 2 months and has had polyuria for the last 2 weeks. She has no medical problems and denies any sexual activity or drug use. On exam, she's alert and oriented. Temperature is 37, pulse 115, respiratory rate 26, blood pressure 114/75. Sats are 95% of room air. The remainder of her exam is unremarkable except mild abdominal tenderness and palpation, and she has a cap refill of 3 seconds. The nurse obtained routine labs, and an arterial blood gas reveals the following. pH 7.21, CO2 at 24, PO2 of 45, bicarb of 10, base excess of -10, and a saturation of 72%. So what is your interpretation of the blood gas? I'm sorry, what's the answer? Answer is D. So it's C or D? Which one is it?
D.
D, very good, okay? So this is kind of a tricky question here, okay? This happens, so you have to be diligent, or I should say not diligent, vigilant when this happens. So the nurse, when she drew the lab, she actually drew it from the venous labs, and that's why the PO2 was so low and the saturation was so low. If you compare that to the saturation on a pulse ox, the patient was saturating 95%. So why is the blood gas 72%? When you see that discrepancy, ask that question, okay? And then soon you'll find out whether it was a venous gas or an arterial gas. Suffice to say, this kid is trying to compensate, though, okay? Why is this kid trying to compensate? What's most likely the diagnosis of this kid? TKA. Okay, so here's where that Kussmaul breathing comes into play. This kid's hyperventilating, all right? But there shouldn't be any hypoxia. Usually you don't see that in this type of situation. Okay? All right, so again, this lab was taken from a venous source and not arterial. That's why you have that abnormality. Okay? So again, when you're thinking about blood gas, the big ones to really focus on when you're studying are typically respiratory acidosis and metabolic acidosis. Okay? All right, any questions? How much more time do I have? Okay, 7 minutes. Do you want me to go into this, or do you want to? I can. I can use 7 minutes, and then we can finish up this afternoon. Okay. All right. Any questions? Okay. I'm going to move into the critical care ones. Obviously, I'm not going to finish this during this hour. I'm just going to go for about another 7 minutes or so, and we'll pick up the rest of it at noon and finish it then. Again, all these slides will be available to you. Okay. All right. So the first question: 9-year-old is struck by a car while crossing the street. His vital signs reveal tachycardia with a blood pressure 120/70. On exam, he's lethargic, has poor pulses, cool extremities, and a cap refill of 5 seconds. Of note, he has a diffusely distended abdomen with pain over the right upper quadrant. You are concerned the patient is currently in hypovolemic shock. Which of the following is a true statement about pediatric patients in shock? Children must have hypotension to be in shock. Altered mental status can be an indicator of shock. Hypotension is defined as systolic blood pressure less than the 50th percentile for age. Systemic vascular resistance decreases during shock. Or E, cardiovascular compensation can be unlimited in a child threatened with poor perfusion. B, very good. So the content specification is recognize that blood pressure may not be adversely affected by shock. And why is that? I always go through this through my shock lecture. I want to put it in here so we can talk about it. So this slide you'll see in PALS. This shows the relationship between cardiac output and compensation. Anything above this line means you're compensating above, and anything below is you're not compensating. So what you notice here is that the mean arterial pressure, as you lose volume, stays the same despite your cardiac output dropping. That's because your systemic vascular resistance goes up and your heart rate. That's a way pediatric patients compensate. However, it's not forever. They usually plateau and stop compensating after a period of time. And if blood volume is continued loss, or there's not correction of why they're in shock, cardiac output will continue to drop, and that's when you start seeing blood pressure drop. So you may not see blood pressure drop in the beginning of shock, maybe later because of compensation. As far as percentiles, blood pressure less than the 5th percentile, not 50th, is considered hypotension in kids. The 50th percentile is pretty much normal. So if you have any of these kids with systolic blood pressures less than these values, okay, that's considered hypotension. Okay? We use typically a formula of 70 plus 2 times age in years for kids between the years of 1 and 10. Okay? I did not put premature infants on here. These are term infants. Okay? All right. Any questions? Next case, a student asks you about the utility of capillary refill testing in pediatric patients. Of the following, the most accurate statement regarding capillary refill testing is that it is affected by environmental temperature, always abnormal if greater than 3 seconds, best measured in dependent extremities, unaffected by inter-observer reliability, or E, unaffected by vasopressor use. A, very good. So understand the factors that affect capillary refill. Okay? The presence of prolonged capillary refill is a mark of global hyperperfusion. Okay? Typically, less than 3 seconds is considered normal, and we typically measure it by holding a non-dependent area of the body above the heart and compressing it until it blanches. Usually a nail bed. I usually typically use a leg because it's a lot farther, so I know if the toe is being perfused, and I think everything else is being perfused. But you can use the hand if the feet aren't available for whatever reason. Okay? It can be affected by various environmental intrinsic factors. For example, it could be prolonged in cold temperatures. This is particularly important in kids. Older patients, patients treated with vasopressors, and any kind of poor light conditions. And they've done studies on this, and they show that there is significant inter-observer variation. Okay, so you have to look at a consistency of observers when you're doing this. Next question, you are evaluating a 5-year-old boy for lethargy. He has been having emesis and becoming increasingly clumsy over the past 4 to 6 weeks. On exam, he's difficult to arouse. He has sluggish pupillary responses and has rapid, deep, sustained breaths at a rate of about 35 breaths per minute. Of the following, the next best step in initial management of this patient is administration of dexamethasone, administration of furosemide, which is Lasix, endotracheal intubation, non-contrast CT scan of the head, or E, urine toxicology. What's that? Okay, it's not E. You want to go back to the question? C. Okay, very good. Endotracheal intubation. Okay, so the content specification is recognize the clinical findings that indicate impending systemic failure or coma. Okay, so here this patient actually had a medulloblastoma that you could see here. Okay, and that was causing him to have elevated intracranial pressure. You can see how his ventricles are dilated on both scans here. Okay, so increasing intracranial pressure can result from a variety of pathologies. In this situation, it's some form of tumor, but it can occur in head trauma, especially intracranial hemorrhages, various types of CNS infections, including meningitis, hypoxic ischemic events, especially like during arrest situations or near drowning issues, or when they have hydrocephalus, whether it's communicating or non-communicating. Right? Clinical signs, such as our patient, is altered level of consciousness, bradycardia, elevated blood pressure, and normal breathing patterns. So basically, Cushing's triad. As far as the respiratory changes, recognize that there are changes depending upon where the lesion is. Okay, here's a nice little schematic of what the various types of respiratory patterns you can see and what areas of the brain are affected. So here you can see Cheney-Stokes respirations. Here you can see a neurogenic hyperventilation. This is what our patient has, so it tells you that the injury or the cause of this altered mental status is most likely in this range, just above the pons. If it involves the pons, then it could be either this apneustic breath-holding pattern or this cluster breathing. And of course, if it's lower down on the brain stem, just superior to the spinal cord, you start to see ataxic or agonal type of breathing. Okay. As far as cardiac, when you see systemic failure, it's a combination of two factors. One is respiratory failure and shock. And when you have those two that occur, eventually you have cardiopulmonary failure. So our job is to recognize early enough to reverse this. Okay? So we don't want to recognize it when they're in respiratory failure. We want to catch it when they're in respiratory distress, otherwise they'll progress. We also want to recognize inadequate perfusion. Fix that before they go into shock. Either way, if they move into this pattern of respiratory failure and shock, the next step will be cardiopulmonary failure. Okay? And if that's not reversed either effectively or efficiently, then they're going to move on to a cardiopulmonary arrest. Okay, I'm going to stop there because I know you guys have clinical things you have to deal with. We'll restart again at this point at noon, and we'll finish up the critical care slides. Okay? Any questions or anything before I go? Okay, if you have any, bring them to me this afternoon.